Welcome to Nurses Lab. We are happy to bring yet another video on AHA 2025 updates. If you not subscribed our channel, please do subscribe, as we are going to update on more videos related to BLS, ACLS, PALS, and NRP with concise informations. This video totally targeting the drugs used during emergency codes, its dosages, and dilution standards, which provides a streamlined reference to the core medications used in adult, pediatric, and neonatal resuscitation. Now, let's dive into the video. Drugs used in AHA, BLS, ACLS, PALS, NRP. In this video, we are going to discuss firstly, about drugs used in BLS, ACLS, NRP, and PALS. Then, the dosage of drugs used in BLS, ACLS, NRP, and PALS. Next, we will discuss about dilution standards for the drugs used in BLS, ACLS, NRP, and PALS. Finally, we will see the dilution approaches to each drug used in BLS, ACLS, NRP, and PALS. First, let's see about the 2025 drug-related updates covering BLS, basic life support. Naloxone, opioid overdose, major visibility increase in this update. The BLS algorithm now explicitly shows where naloxone fits during suspected opioid overdose, which was discussed in detail in our previous video. Link in the description, you can watch that later. In this 2025 updates, special emphasis is given on naloxone. When it comes to naloxone, there were a lot of misconceptions in the previous updates. Now it is very clear that naloxone may be given during respiratory arrest and may be considered during cardiac arrest when opioid toxicity is suspected. Points to remember. Naloxone is not a substitute for high-quality CPR and early defibrillation. ACLS, Advanced Cardiovascular Life Support, 2025 drug updates. The 2025 ACLS update focuses on consistency, timing, and integration of medications rather than introducing new drugs. ACLS medication considerations. Although the guideline summaries do not list new drugs, the following medication domains were highlighted in the updated ACLS curriculum. Vasopressors. Epinephrine remains the primary vasopressor for cardiac arrest. Emphasis on timing, early administration in non-shockable rhythms. Antiarrhythmics. Amiodarone and lidocaine remain acceptable for refractory VF/PVT. No new antiarrhythmic agents were added in the 2025 summaries. Opioid-related emergencies. Reinforced alignment with BLS, naloxone use when opioid overdose is suspected. Post-cardiac arrest care. Medication use, vasopressors, antiarrhythmics, sedation is emphasized within a standardized post-arrest bundle, though no new medications were introduced in the current updates. PALS, Pediatric Advanced Life Support, 2025 drug-related updates. The 2025 PALS update focuses more on early recognition, respiratory support, and systems of care rather than new medications. Emphasis on medications. Epinephrine timing remains critical. Early administration in non-shockable pediatric arrest. Shock and respiratory failure management. Medications, fluids, vasoactive agents remain part of standard PALS, but they are not changed in the 2025 summaries. No new pediatric resuscitation drugs were introduced in the guideline highlights. NRP, Neonatal Life Support, 2025 drug-related updates. The AHA 2025 guideline documents covers neonatal life support, but does not list new drug changes in the publicly available summaries. Epinephrine remains the primary medication for neonatal cardiac arrest when HR less than 60 despite ventilation and compressions. Volume expanders, normal saline, remain unchanged. No new neonatal drugs or dosing changes were reported in the 2025 guideline highlights. Dosage of drugs used in 2025 AHA updates. Epinephrine. Indication for epinephrine in adults is cardiac arrest. Dose for epinephrine in adults is 1 mg every 3 to 5 minutes. Route for epinephrine administration in adults is IV or IO. Indication for epinephrine in pediatrics is cardiac arrest. Dose for epinephrine in pediatrics is 0.01 milligrams per kilogram, 1 to 10,000 concentration, every 3 to 5 minutes. Route for epinephrine administration in pediatrics is IV or IO. When it comes to neonates, epinephrine is used if HR less than 60 despite ventilation and compressions. Dose for epinephrine in neonates is 0.01 to 0.03 milligrams per kilogram, 1 to 10,000 concentration. Route for epinephrine administration in neonates is IV or IO. Amiodarone. Indication for amiodarone in adults is refractory VF/PVT. Dose for amiodarone in adults is 300 milligrams bolus and may repeat 150 milligrams. Route for amiodarone is administration in adults is IV or IO. Indication for amiodarone in pediatrics is refractory VF/PVT. Dose for amiodarone in pediatrics is 5 milligrams per kilogram and may repeat. Route for amiodarone administration in pediatrics is IV or IO. When it comes to neonates, amiodarone is not routinely used in delivery room. Lidocaine. Indication for lidocaine in adults is refractory VF/PVT. Dose for lidocaine in adults is 1 to 1.5 milligrams per kilogram. Repeat 0.5 to 0.75 milligrams per kilogram. Route for lidocaine administration in adults is IV or IO. Indication for lidocaine in pediatrics is refractory VF/PVT. Dose for lidocaine in pediatrics is 1 milligram per kilogram and may repeat. Route for lidocaine administration in pediatrics is IV or IO. When it comes to neonates, lidocaine is not routinely used in delivery room. Adenosine. Indication for adenosine in adults is supraventricular tachycardia. Dose for adenosine in adults is 6 milligrams rapid push followed by 12 milligrams. Route for adenosine administration in adults is IV. Indication for adenosine in pediatrics is supraventricular tachycardia. Dose for adenosine in pediatrics is 0.1 milligram per kilogram followed by 0.2 milligrams per kilogram. Route for adenosine administration in pediatrics is IV. Indication for adenosine in neonates is supraventricular tachycardia. Dose for adenosine in neonates is 0.1 milligram per kilogram, then 0.2 milligrams per kilogram. Route for adenosine administration in neonates is IV. Atropine. Indication for atropine in adults is symptomatic bradycardia. Dose for atropine in adults is 1 milligram every 3 to 5 minutes, max 3 milligrams. Route for atropine administration in adults is IV. Indication for atropine in pediatrics is bradycardia, usually rare. Dose for atropine in pediatrics is 0.02 milligrams per kilogram, min 0.1 milligram. Route for atropine administration in pediatrics is IV or IO. In neonates, atropine is not recommended in delivery room. Magnesium. Indication for magnesium in adults is torsades de pointes. Dose for magnesium in adults is 1 to 2 grams. Route for magnesium administration in adults is IV. Indication for magnesium in pediatrics is torsades. Dose for magnesium in pediatrics is 25 to 50 milligrams per kilogram. Route for magnesium administration in pediatrics is IV. In neonates, magnesium administration is not recommended. Naloxone. Indication for naloxone in adults is suspected opioid overdose. Dose for naloxone in adults is 0.4 to 2 milligrams and repeat as needed. Route for naloxone administration in adults is IV/IM/IN. Indication for naloxone in pediatrics is opioid toxicity. Dose for naloxone in pediatrics is 0.1 milligrams per kilogram. Route for naloxone administration in pediatrics is IV/IM/IN. In neonates, naloxone administration is not recommended. Dextrose. Concentration of dextrose used in adults is D50 in water. Dose for dextrose in adults is 25 grams. Concentration of dextrose in pediatrics is D25 in water. Dose for dextrose in pediatrics is 2 to 4 milliliters per kilogram. Concentration of dextrose in neonates is D10 in water. Dose for dextrose in neonates is 2 milliliters. Calcium. The form of calcium used in adults is calcium chloride 10%. Dose for calcium in adults is 1 gram. Route for calcium administration in adults is IV. The form of calcium used in pediatrics is calcium chloride 10%. Dose for calcium in pediatrics is 20 milligrams. Route for calcium administration in pediatrics is IV. The form of calcium used in neonates is calcium gluconate 10%. Dose for calcium in neonates is 100 milligrams. Route for calcium administration in neonates is IV. Fluids for bolus. Types of fluids used for bolus in adults is crystalloids. Dose of fluids for bolus in adults is 500 to 1,000 milliliters. Types of fluids used for bolus in pediatrics is crystalloid. Dose of fluids for bolus in pediatrics is 20 milliliters per kilogram. Types of fluids used for bolus in neonates is normal saline. Dose of fluids for bolus in neonates is 10 milliliters. Dilution standards for common resuscitation drugs. In this chapter, we are going to discuss about dilution standards used during resuscitation according to the 2025 AHA recommendations and standard practice. Firstly, let's discuss about epinephrine. For bolus administration, 1 to 10,000, 0.1 milligrams per milliliter is the standard dilution recommended for all ages, usually comes in pre-filled syringe. For infusion, the dilution recommended is 1 milligram in 100 milliliters, that is 0.01 milligrams per milliliter. If we see its considerations, neonatal resuscitation uses the same 1 to 10,000 concentration for IV/IO administration. Endotracheal dosing uses 1 to 1,000 diluted with NS to achieve larger volume. Next, we'll discuss about amiodarone. For bolus administration, undiluted 150 milligrams per 3 milliliters or 300 milligrams per 6 milliliters will be the standard dosage. If given as infusion, then the dilution will be 150 milligrams in 100 milliliters D5 in water, that is 1.5 milligrams per milliliter. If we see its considerations, it must be given with a filter when infused to prevent crystals entering bloodstream. It is usually not used in neonatal resuscitation. The next is lidocaine. For bolus administration, 100 milligrams per 5 milliliters, which is equal to 20 milligrams per milliliter, will be the standard dosage. If used as infusion, 1 gram in 250 milliliters, that is 4 milligrams per milliliter, or 2 grams in 500 milliliters, that is 4 milligrams per milliliter in 100 milliliters, and is equal to 0.01 milligrams
per milliliter. If we see its considerations, pediatric bolus uses the same concentration. It is not used in neonatal resuscitation. Adenosine. Usually, the dosage is 3 milligrams per milliliter, and it will not require any dilution for administration. Adenosine will not be administered as infusion. The considerations are must be given rapid IV push with immediate flush. Same concentration for neonates with SVT. Atropine. In adult bradycardia algorithm, the dilution is 1 milligram per 10 milliliters, that is 0.1 milligrams per milliliter. In pediatrics, 0.1 milligrams per milliliter standard vial is the dosage. When it comes to neonatal resuscitation, atropine is not used. Magnesium sulfate. In adults, during torsades, bolus of magnesium is used, and its dilution is 1 to 2 grams in 10 to 20 milliliters D5, while in pediatrics, during torsades, 50 milligrams per milliliter diluted to 10 to 20 milliliters for slow infusion is the standard dosage. In neonates, magnesium is not used. Naloxone. In adults, the standard dose used is 0.4 milligrams per milliliter or 1 milligram per milliliter without dilution, whereas in pediatrics, the dosage of naloxone is 0.4 milligrams per milliliter without dilution. In neonates, not routinely used. Dextrose. In adults, the dextrose used is D50 in water, 50% of dextrose. In pediatrics, the dextrose used is D25 in water, 25% of dextrose, often prepared by mixing D50 1:1 with NS. In neonates, the dextrose used is D10 in water, 10% of dextrose, standard neonatal concentration. Calcium. In adults and pediatrics, the dilution standard of calcium chloride 10%, 100 milligrams per milliliter. In neonates, the dilution of calcium gluconate 10%, 100 milligrams per milliliter, preferred due to lower tissue injury risk. Fluid bolus solutions. Fluids used during resuscitation commonly is normal saline without any dilution, and in adults, ringer lactate is also used. Dosage depends on the clinical requirement during resuscitation.
Standard approach to diluting resuscitation drugs. In this chapter, we are going to discuss about the standardized approach to dilute the drugs used during resuscitation in order to be very clear when encountering emergencies. Before going to discuss in detail, let us know the stock concentration of the drugs used during resuscitation. Epinephrine. It is available in 1 to 10,000, 0.1 milligram per milliliter. Amiodarone. It is available in 150 milligram per 3 milliliters. Lidocaine. It is available in 20 milligram per milliliter. Adenosine. It is available in 3 milligram per milliliter. Atropine. It is available in 0.1 milligram per milliliter. Magnesium sulfate. It is available in 50%, 500 milligram per milliliter. Naloxone. It is available in 0.4 milligram per milliliter. Dextrose. It is available in 50%, 25%, 10%. Calcium chloride. It is available in 10%, 100 milligram per milliliter. Now, let's see how to identify the target concentrations we will see with some examples. Epinephrine infusion, 1 milligram in 100 milliliters. Dextrose for pediatrics, 25%. Dextrose for neonates, 10%. Magnesium for torsades, diluted to 10 to 20 milliliters. Amiodarone infusion, 150 milligram in 100 milliliters. Next, let's apply the standard dilution formula. A universal dilution formula works for all drugs is final concentration equals drug amount divided by total volume, or in a rearranged method, total volume equals drug amount divided by desired concentration. The next approach is to choose the correct diluent. Resuscitation drugs typically use 1 normal saline
NS, 2, D5, especially for amiodarone and magnesium, and 3, sterile water, which is rare in resuscitation. Thank you for watching this video. We hope this video brings essential resuscitation medications together in a clear, unified format, supporting rapid learning and consistent preparation across adult, pediatric, and neonatal care. If you like this video, kindly subscribe, like, or write in your comments. Please don't forget to share this information with your friends and colleagues. We'll see you in our next video. Stay tuned.